So good morning, ladies and gentlemen, and thank you for coming to this 60-minute session sponsored by Microport. My name is Darren Mylett. I'm an interventional cardiologist in Galway, and I'm joined by a panel of stars of Angela McInerney, Oscar Mendez, Ole de Backer, Dr. Zhang from China. Thank you for coming all this way, a little bit jet-lagged. And the idea of this session over the next 60 minutes is to introduce you to the Microport transcatheter aortic valve system, to tell you a little bit about the system, to give you some information on their longer-term follow-up data from their pivotal study that's been done in China, and also to show you a nice case that Ole recently performed. The other thing to mention to you is that the concept of this room is a little bit different to most other rooms that you've been in before. I can see that many of you are drinking coffee, so I'm going to have to be careful about who I throw this at. But ultimately, the idea here is that we're going to get you guys to comment on what you've seen, to engage with you, and have this as a conversation between us rather than the usual boring conversations that we have together. So let's try. Jaffer, you got it catching? Okay, good. Let's have it back again. Okay, who else do we see? Maggie, you like this? There we go. You can send it back. Nacio, that laptop is going to have to go away, my friend. Okay, so you get the drift. What you can do is speak into this. This is a microphone. Bernard, over there, I see an engineer from Galway. Excellent. See that? Good hands on people from Galway. And so the idea, again, is that we get you guys to comment and to talk to us, and so be careful because this might come at you. So let's tell you a little bit about the Microport system. You see the picture on the screen. This is the VitaFlow Liberty valve. It's a mixed density, self-expanding valve. By mixed density, I mean that there are very open, it's an open cell design at the top, and as you go from the top down towards the bottom, you get a more closed cell design. It has a quite impressive radial force at the bottom of the valve, yet it's very, very flexible at the top of the valve because of that mixed density. The valve is superannular design, of course. We got bovine pericardial leaflets, and that PET double layer skirt is really impressive in terms of reducing the risk of paravalvular leak. One thing to notice is that frame is tubular shaped. It does not come in a whole lot like other self-expanding valves. And there are certain advantages to that in terms of effective orifice areas. There's also some disadvantages that you need to be very careful about the risk of coronary occlusion in these when using this device. The device comes in 4 sizes, 21, 24, 27, and 30, and it covers an annulus range. I work in perimeters from 53 to 91. So really a good range of sizes. I mentioned that the tubular shape gives you a good orifice area, but again, if you have narrow sinuses, these type of valve designs you need to be a little cautious with in terms of the risk of coronary occlusion. The picture on the right is a very common picture with this device as you're deploying it. You'll notice that there's almost a bend in the center of the frame, and that's because of that difference between the very stiff bottom portion of the valve and the much more flexible top portion. That makes it quite a nice valve for example, horizontal anatomies. And other thing to notice is the way that the valve frame comes in at the top, and that we think is probably a little bit safer in terms of aortic dissection. One of the unique things about this device is that it has a frame that is not really seen elsewhere on the market. So it has an electronic delivery. There's a single speed in terms of delivering a device. This can lend itself to being a single operator procedure. Ole has a case later on. Let's see how you deal with that, Ole. Otherwise, it's a 19 French design. It has an inline sheath, and the valve, the delivery system, as you see, is quite flexible. I've had one case where the battery didn't work. Stephen, I'm very upset with that. But there is a manual release knob on the back end in case that happens. But again, with a lot of cases, I think it happens very rarely. So what I might do is hand these around. Oscar,
maybe you should explain the simplicity of it. Yes, it's just this is the second generation. Yes, the 2. So it's just on and off at the ends. So you basically turn it on, and then it's written on it, either you deploy, and that goes at a certain fixed speed, or you retrieve. Yeah, so it's extremely easy, to be honest. You can, I will give it a round, so you can play with it.
So as you can go ahead and deploy that and release it. Maybe don't deploy the valve completely, but you'll get a feel for the speed of the valve deployment.
Yeah, maybe don't deploy fully because then it pops out. But it's
Oscar, while the guys are playing with that, and please pass it around the audience. You've got a lot of experience in Argentina with this valve. What are the parts of this valve that you like, and what are the parts of this valve that you think could be improved relative to other systems?
Good morning. Thank you for the invitation. We have been working with this valve for the past 2 years, almost, with the first and the second generation. I think you already mentioned the most important thing or characteristics of the valve, which is this tubular shape, this very smooth release, which allows you to deploy the valve in really the target place that you selected from the very beginning. So this tubular shape prevents the valve to dive into the LVOT during releasing. So it's a little bit different when you are deploying this valve in comparison with other self-expandable valve, where we start a little bit up of the annulus, especially for very angulated aorta. This is a very good example you already showed. It's almost an horizontal aorta. You start where you want to finish, and the valve is going to stay there. And this flexible upper part is also important, because when the valve is almost delivered at 60 or 70%, the valve can deflect a little bit. And then this is, in altogether allows you that in very difficult anatomy, you can end up in the target place you have already selected from the very beginning.
Okay, so very stable deployment is what I'm hearing, and good for angulated anatomy. Can I ask, does anybody here have experience using this valve in your centers? Is there anyone in the audience that has used this yet? No? Okay, so just us. Angela, we spoke a little bit about the radial force of the device. How does it compare for you to other devices?
Yeah, so this device is a unique design insofar as you've already seen how it has quite open cells in the upper part of the outflow of the device, but then actually more dense cells at the annulus. And that actually gives it much more radial support than a lot of other self-expanding valves that we use in common practice. So because of that, and in combination with the double skirt that it has, an inner and an outer skirt, you get a lot less paravalvular leak. You get very minimal gradients, even sustained out to 12 months, as we'll see in some of the data later on. And you get a really good, stable, coaxial result with this valve, as we've already mentioned, because of its flexibility.
Yeah. Jaffer, I'm going to come to you, because we just had a session a few minutes ago about long-term durability and the impact of valve design on revalving. Assuming that you get a good result with this valve, you get little paravalvular leak, any of those features that you think, ooh, we need to be careful about that in the future? For example, I'm thinking a lot of radial force can give you pacemakers. Okay, that's not necessarily a good thing. What about revalving this valve?
So I think for revalving, you've got to consider what the neoskirt height will be. So where is this annular? Is it supraannular? How tall do the leaflets go? Do they bend in? Do they bend outwards? And then also the size of the cells around them. And then the final thing would be commissural alignment. Can you align this valve commissurally?
Okay, so in terms of the frame height or the neoskirt, it's going to be up around 24, I think. In terms of the cells, very large cells for coronary access, and in terms of commissural alignment, they're working on it. It seems like it's going to be a Medtronic-like solution in terms of getting it right in the ascending aorta, rather than an accurate neo-like solution where you're going to be rotating the valve at the level of the annulus. Yeah. Thank you. From the audience, any other questions about the design of this valve, Ignacio? Anything that comes to mind?
I was wondering if
you're going to have to hold that up.
If you are a little bit too low, since there is so much radial force distally, but is weaker proximally, is there a risk of ventricular embolization? You know?
Okay. Oscar, if you go a bit low, all that radial force, can it push you down?
Yeah, this is a very good question. In our experience, which is not so big, but we have done a lot of cases in Argentina in different centers, we haven't had this such experience. Actually, it's much less than other self-expandable valves, where you usually have some diving into the LVOT. So to be short, I would say no, it never happened.
I think so too. I mean, I think really that's the difference between if you compare these self-expanding platforms with how much waste they have. If they're rather tubular on the inflow part, they're typically very stable with final release. That's my experience, at least. It's not only for this valve, it's also with other valves where it's more tubular style. I almost never see it sinking in. On the opposite, if you go extremely high, you may have, if you've done a lot of oversize and the aortic root is large and you sit there with something very high implanted, that may even milk itself a little bit up, yes? But going down, I mean, I've limited experience with this valve, but the cases we all did, Darren was also there, I mean, they were extremely stable. With final release, they didn't move a millimeter. Also, we could get them implanted pretty symmetrical. Yes, so it's thanks to because what is the advantages of a stent frame which is much more open at the outflow part? There's multiple. It's the obvious one is to say, yeah, it's better for coronary access. But what it does as well is that it makes the valve, when you cross the arch, it makes it more flexible typically, and the valve can easier bend. And then also when you're placing the valve, before you final release, that the valve kind of more easier self-centers. So I think having less nitinol in that outflow part has a lot of advantages, to be honest. And I think that's the way forward.
So maybe one question before we ask Dr. Zhang Zhaocheng to present the 7-year echo data follow-up or echo follow-up. Does that stability, guys, does it come from the electronic delivery, or does it come from that slightly stiffer frame? What do you think? Because, you know, what are the advantages of this electronic delivery? Is it a gimmick, or does it maybe offer some advantages? I don't know the answer.
Me neither, but if I had to guess, I would say that probably the valve design is more important for the stability than the electronic delivery, because actually you can deliver manually if you want, but the electronic delivery is easier in case you are a single operator, which is not so common, but in case you need it, you can do it. But in my opinion, the valve design is more important for stability than the electronic delivery.
Okay, perfect. So at that, let's ask Dr. Zhang Zhaocheng from Zhongshan Hospital in Shanghai to present the 7-year clinical outcomes from the MicroPort VitaFlow study.
I'm glad to be invited to give a presentation in London Valves. This is my first time in London Valves. I think I can come here next year. I can give you, will introduce the 7 years outcomes of the follow-up of the first TAVI in China in high surgical risk patients with severe aortic stenosis. Okay, the first part of the report, the study design. The objective is to evaluate the safety and effectiveness of VitaFlow valve and the delivery system in systematic patients with severe calcific aortic stenosis who are considered unsuitable for surgical valve replacement. It has designed as a prospective multi-center single-armed trial. It had enrolled 110 patients enrolled the period from the October 2015 to 2015 to September 2016. All patients will be followed up at least 10 years post-TAVI. The primary endpoint is all-cause mortality at 12 months, and the secondary endpoint includes device success, procedure success, and major stroke, and so on. The PI and the co-PI covered the 4 largest structural hospitals across China. The PI is Dr. Ge Junbo, the director of Zhongshan Hospital of the University in Shanghai. Let's see the patient's flow chart. We enrolled 110 patients, and some patients die of the COVID-19 epidemic in the 2020 and 2022. And there are still 83 patients left after 7 years. The second part of the 7 years clinical outcomes is a patient baseline. The mean STS score is 8.8%. And the BAV patients account for about 40%. The all-cause mortality is 31.4 at 7 years. And these are major complications at 7 years. Cardiovascular mortality is about 15%, and about 16% patients had myocardial infarction, and about 25% of patients had a new permanent pacemaker implanted. And 3 of the 60 patients with severe aortic regurgitation at the 7 years follow-up, all severe aortic regurgitation were in intraprostatic regurgitation. And the bioprosthetic valve failure occurred in the 3 patients. In total, 8 patients with moderate to severe structural valve deterioration. Comparing the 60 patients from 30 days to 7 years, hemodynamics maintained. The VitaFlow valve performs well, I think. The hemodynamics showed no difference between bicuspid and tricuspid patients at 7 years. Let me make a summary. With all-cause mortality of 31.4% at 7 years, the results suggest that the VitaFlow safety and efficacy has been maintained over long term. The efficacy of VitaFlow has been supported by excellent hemodynamics and low level of SVD and BVF at 7 years. Similar valve performance before being observed between patients with bicuspid and tricuspid anatomy. Okay, thank you.
Thank you very much.
Thank you.
So I think those data are worthwhile, or certainly worthy of discussion. First thing to say is that this study was designed for 1 year follow-up at the time, and the company, as far as I understand, don't have 2 year, 3 year, 5 year, 6 year, and so 7 year echo data I think was quite a stretch to get. But this is core lab adjudicated data. Ole, how do these results compare to Notion at 7, 8, 9 years? What are your thoughts initially?
Well, it's the first time I see these results too myself. So I think what I take as take-home messages here, or what fell into my eye, is first of all, it's a trial with a lot of bicuspids in. Yes, this you never see in all the other studies. Also in Notion or low-risk trials from Partner 3 or Evolute Low Risk, there's no bicuspids in. So that's impressive. 42% bicuspid patients. And then if you look to procedural safety, excellent data, I think. Pacemaker rate on the slightly higher end, 20%. Yeah. I think early experience, a high number of bicuspids, where we know the risk of pacemaker, but typically these patients also have a shorter membranous septum, so that's still acceptable. And I think we, in the tricuspid arm and with increased experience, this probably is easy to get down to 10.
Yeah. Well, one thing I would say is that most of these patients were implanted in the areocaudal view, so that has dropped many of our pacemaker rates from 20 down to 15. But most of these patients already had this at the start, just to say that, right?
Yeah, that could be. But then even sizing-wise, sometimes there's something to learn about sizing. That's also my personal perspective on how you size TAVI valve for your valve choice. I mean, like the reflex almost that we have with self-expanding device to kind of, if we are in the borderline zone, to go for an oversized valve, as we do with core valve Evolute. I think if you have that tubular part of a valve, you typically don't do that. So I'm not sure how much that was implemented already there. But anyway, I think valve performance overall, what you show up to 7 years, impressive. I mean, these hemodynamics, these mean gradients stay below 10 millimeters mercury. So that seems excellent. I don't know if there's any data about clinical valve thrombosis. Do you have some data about this? Was there any valve thrombosis seen in any of the valves? Thrombus on the valve? Have you seen that or not at all? That's also interesting to know to me.
I think the high pacemaker implanted because the 2015 one generation is uncovery. It's an uncovery system. So I think the pacemaker implant rate is pretty high.
Yeah.
So not sure there's data specifically on valve thrombosis.
No.
Certainly there was no systematic CT
Probably if you
follow-up
look to
or
the
anything.
data and the SVD numbers that are reported there, and that's going to be very low, yes. And that's not a surprise. I think that's then the gain of having a little bit supraannular leaflet position. That's typically good in preventing that.
Where do we come down on those 3 cases of severe transvalvular regurgitation? Oscar, maybe you want to take that one. Three cases out of 110 is not a whole lot, but 3 out of 82, which is actually the echo follow-up, that's a little higher.
Well, could be higher, but to me it's not too much at 7 years with the early experience with the first device design with probably a lot of bicuspid. We don't know how much elliptical shape we have had in this population, so it might be or it might have affected this possibility of late thrombosis. This is one possibility. The other thing I wanna point it out, I agree with Oli that probably close to 20% pacemaker rate is high, but this is 7 years experience. Casper Lab View was developed and mostly accepted probably 3 or 4 years ago. So probably most of these implantation were done in the coplanar view, especially for bicuspid. So I think it's high, but I think we have explanations for that.
And I suppose we can probably expect a slightly higher pacemaker rate, given that this device is specifically designed for that heavy calcification and bicuspid anatomy that's often seen in China. So having a slightly higher pacemaker rate is probably a trade-off to a certain extent when you're treating those type of anatomies. Angela, it seems like the echo data is nicely maintained with EOAs and gradients that remain low after 7 years. What are your initial thoughts of it?
Yeah, I think it's really impressive data, actually. Obviously, there's some attrition of patients out to 7 years, but having echo data that shows that you're maintaining gradients with EOAs of 1.82, etc., in this device is actually really encouraging, I think, for using that device. I think the pacemaker rate, certainly, as we get to know the device, should actually come down, as it has done with all of our other devices, as we've gotten more familiar with using them and implant techniques, etc.
Okay. Oscar?
Yeah, probably one observation from this data about the echo is there was a little increase of the area between 1 and 3 years. So maybe it needs some explanation. I don't see this, this curve with the other valves. Maybe Professor can explain us.
Yeah. So the question is that there seems to have been a change in the echo. Could we bring the slides back up again and let's have a little look at that? That there seems to have been a slight increase in the gradient or the EOA?
Area.
EOA. In the EOA. So could we bring up the previous slide deck, please? And let's have a look at that.
Or should we do that?
While we're doing that, tell me any questions? Yeah, great. Catch. Oh, you nearly showed yourself up there, huh?
A question, how were the patients with bioprostatic valve dysfunction treated? Those 3 patients with severe regurgitation, is it possible to perform a THV with what kind of device? What are the risks of the THV with this valve?
Do we know anything about the 3 patients who had severe aortic incompetence? It seems that 1 patient went to had surgery. How were those patients treated? Did they have TAVI and TAVI? TAVI and TAVI.
TAVI in this year.
Okay.
In this year.
Okay. With a self-expanding valve. Do we know the details of those cases?
No. Self-expanding valve.
Okay. So I again, with that tubular shape, you need to have big sinuses for TAVI and TAVI to be an option for sure, as Jaffer mentioned to us. Pass it on.
Was it paravalvular or valvular?
No, it seems like the 3 cases were all transvalvular, so a leaflet issue rather than non-structural failure.
What is the size of the thickness of the pericardium?
That's a good question. The guy who designed the valve is there, Stephen. What's the thickness of the pericardium, the bovine pericardium?
It's around 0.3 millimeter. Yes.
0.3 or 1.3?
0.3.
0.3, so very thin pericardium.
Yes.
Okay, thank you.
Mm-hmm.
Yeah.
Predilate the valve before the implantation, or?
Do we routinely predilate? Maybe Dr. Zhang, in your experience, are you routinely using a balloon to predilate when using this valve, or you go for direct valve implantation?
Go direct.
So are you predilating with a balloon valvuloplasty, and then putting in the microport, or just the microport?
Make a balloon first.
A balloon first. And maybe Oscar, you want to tell us about your experience?
Especially for a bicuspid valve or heavily calcified valve. They're similar to other self-expandable valve. If it's not so calcified, we go with, direct implantation.
Okay, so similar to most other systems. Okay. Any other questions in relation to these data? Oscar, you wanted to look at that little bump. It looks like it's 12 months, huh? That there's a big gap between 12 and 48 months. So hard to know why that EOA would go up a little bit.
But to emphasize, I think that if between 30 days and 6 months, I think it's within the variation. I think there's no big jump there.
Over here?
Yeah.
You have around immediately 1.8 plus. You see the standard deviations. It's plus minus 0.5. So I think.
Okay.
Yeah,
so within the standard deviation. Okay. The curves are zoomed up. Okay. Any other questions in relation to those 7-year echocardiographic follow-up? I hope the company are going to continue to do more and do 8-9 years, because as Ole suggested, especially in that bicuspid group, that's really important data. We don't have that data in others. So good to see that the bicuspid and the tricuspids seem to be evenly matched. Catch.
Are these data with reduced orifice area concomitant with microcalcifications in the leaflets? Because this seems, the crimping, we know that they create some kind of damage, and depending on the anti-calcification treatment, it might be very well that this drop in orifice area is the stiffness, and the stiffness is due to the fact that there is calcium. Did the company look for that?
If I understand correctly, did the company correlate the change in gradients, increasing gradients, for example, in certain patients with calcium on the leaflets? I don't think that's been done, to be honest. Certainly not with CT scan, but maybe they could look at it with echo and try and understand that a little bit better. Okay. Ole, it's probably time to go and have a look at the case.
Yeah, let's do that.
So maybe you might explain to us the case. So Ole's got a case he's going to present to us. We can talk a little bit about the case, and then we have the actual implant video that Ole shot live in Copenhagen.
Okay, maybe give me the clicker, then it's easier to go through. And then, all right, good. So that's a case we did, I don't know, a couple of weeks ago. And this is a classical aortic stenosis patient. So 78-year-old male, pretty large male. Yes, 186 centimeters, 92 kilos, but normal BMI 27. Classical hypertension, hypercholesterolemia, otherwise no other comorbidities. So this is a perfect patient, I think, for us in Copenhagen to treat with TAVI. He presents also with the classical symptoms, dyspnea, NIA class 3, and he has severe high gradients. I can show you this here. Ejection fraction nearly preserved, 55%. He has really high gradients. You see, he has a mean gradient of 85 millimeters mercury, AVA of 0.6. He has a normal ECG. We did not do a coronary invasive coronary angiogram, as we do in 60% of patients. Not if we see on the CT, patient has no previous coronary artery disease, no previous PCI, he has no angina symptoms, and you see on the CT, the proximal segments are free of calcium. What would be the reason to do a coronary invasive coronary angiogram? So there was nothing to be seen on the CTA. The labs are impeccable, I think, and then STS is of course low, 1.1 in this patient. Yeah. And then the CT, most interesting, most important. So perimeter for this relatively large male patient, it's actually not that large anatomy in a way. Perimeter of 76, so perimeter-derived mean of 24. You see aortic annulus and LVOT, very comparable, maybe a tiny bit more smaller tubular into the LVOT, but there's no calcium whatsoever. And then the maximum diameters there are 27.4, 27.5. Okay. Then if we look to the sinus of Valsalva, large, compatible with the annulus size, I would say, between 31 and 33 millimeters. ST junction around 29 to 30, no calcium there. And then we really always assess the calcification, the amount of calcification, not only in that hockey puck view, which can sometimes be misleading. It's always important to scroll up and down through these leaflets as well, I would say. And to me, this is really severely, it's a tricuspid, but severely calcified leaflets with a normal distribution, but with a lot of calcium on the tips of the leaflets. Then coronary height, as Darren said, important to assess this as well. So I would say no problem here. Distances of 18 to 20 millimeters above the annulus, that's typically not an issue. Also with that ST junction of around 29 to 30 millimeters, we don't foresee any issues there. And then the angulations you see on the right-hand side, that's the way to measure indeed your aortic root angulation. You do this in a tricuspid-planar view. That's a very neutral angulation, 48 degrees. And then the right-left cuspovula view, you will see us using this, I think, in the to do the initial deployment of the valve, and REO 16 caudal 24, so that's a very feasible angle to reach. Then we see the arch of the aorta, nothing particular, not a very steep arch, anything fine. Also the ascending aorta, pretty nice length. It's not a very short amputated ascending aorta, so very classical, I would say. And then the excess vessels, also very nice. There's no calcium, not very tortuous, and good diameters. So the plan here, transfemoral TAVI and local anesthesia, and that's really pure local anesthesia. There's no anesthesia in the room for our cases. There's a right femoral access planned with a pre-closure with one single prostyle. We used here cerebral embolic protection. We can go further into that or not, that's up to you. And then pre-dilatation with a 22 millimeter balloon. I think that's matching more or less the minimum diameter, if I remember well, was around 20. The max diameter was 27, the perimeter-derived mean was 24. So you see, we took there a balloon choice between the minimum diameter and the perimeter-derived mean, which was 20 and 24. So we took a balloon somewhere in the middle, 22. And then this one, anatomy is suitable for a VitaFlow to 27 millimeter. Yeah.
Okay, so maybe we have a few minutes to discuss the case with you guys and see what you think. Of course, if there's not a lot of experience in the room with the VitaFlow device, what other device would you choose? Jaffer, fairly straightforward case in your lab. What would you use? What are the things you would be considering for this patient?
So I think one of the things to consider is that it's a slightly small annulus compared to the body size of the patient. So I think I'd consider hemodynamics. With that, also, it's a very heavily calcified leaflet, so I'd either want something with quite a strong opening force or balloon predilate. I think those would be two of the things that I would consider in this patient, and then I agree with the rest of the plan.
Okay, so would you take, for example, in light of needing that extra push, would that push you towards a balloon expandable valve? Or would you think, well, the hemodynamics are maybe a bit important here, a supraannular valve, self-expanding?
Well, exactly. That's what I'm kind of angling at. So I think I think we could probably go straight up with a balloon expanding valve, avoid predilation. But I think just a little wary about the actual size of this patient. Maybe a self-expanding supraannular valve with balloon predilation. I'd probably go. Personally, I choose a balloon with the minimal diameter. Maybe it's being a bit wimpy, but that's just how I.
Okay. A little bit less aggressive with the pre-dilatation.
Okay. I agree. That depends sometimes on what type of balloon. If I would go for a non-compliant balloon, a true balloon, I would also go not maybe immediately to 22. I think we didn't have on that moment the true balloons in our lab, so we had a more semi-compliant balloon. Osipka balloon. So then the 22 also anticipating if we would have to post-dilate, we don't have to open another balloon of a couple of €100 for no reason. So, I mean, it's kind of a compromise there.
Even looking at the area here, I mean, this is pretty much a 23 balloon expandable valve.
Yeah.
So that your concerns, Jaffer, may be about gradients, etc. In this 92 kilo gentleman are well founded. Any other comments on this case? Anyone else feel that a particular in their practice what you guys would do?
I would take into consideration same things. And then for the vascular access, we are dealing here with 18 French. I don't know if I would use only one on prostate.
Okay, that's really interesting because we're gonna see how that pans out, right? You would take 2 prostyles because of the slightly larger French size?
It's a very favorable vascular access, but still, for me, it's a new valve. I don't know it. I don't know how flexible it is, how it's going to behave. 18 French. So for my first case, I think I would use 2.
Yeah, no, that's a good comment. And if I'm being honest, maybe one of the things that could be better, and we've seen it with other self-expanding devices recently, is the nose cone. Right, we've seen the Evolute FX being redesigned. It's got a nose cone that is now more like a sheath. It's a little bit longer, whereas this has that more traditional, shorter nose cone. So careful access planning, I think, is important. Oscar, have you seen vascular complications with this? We see vascular complications with every device, but more vascular complications with this device, or what are your thoughts?
No, unfortunately, we haven't had more vascular complication, maybe because we were lucky enough, but probably, in this case, femoral access was normal, so I will still use only one ProLite and then one angioseal at the end.
Yeah, I don't know. I've struggled a little bit with this as well. Sometimes I thought, I'm safer if I've got two ProGlides, but sometimes they seem to interact with each other. You pull one, it kind of pulls on the other, and I don't know. I'm between the two.
It took me a couple of months to convert completely, but indeed, this is my impression too. Sometimes, my rule is if you have a smooth puncture and a super smooth, good deployment of your ProGlide or ProStyle there in the beginning, everything runs, and you have a good feel about it, it's better to leave it probably with the one. Because if you add a second one, sometimes the interaction of it makes it actually just worse. But okay, that's a small...
Yeah. And honestly, I don't see much, people talk about stenosis that they leave behind with 2 ProStyles. I don't see much of that. So it's not for that, and it's not for economic reasons. I just wonder sometimes do they interact and actually don't close as well. Angela, you were going to ask.
Yeah, well, just to make a comment on that, I think it's really interesting how we're just always learning in the field at TAVI, because we'll see how this was closed later on, and actually this is what we've now adopted in Galway, and we've had really good success with it. And I think we're always learning, even small little things can kind of add to the efficiency of your procedure. But I'm just interested if we could maybe take a vote. I actually saw there's quite a lot of implanters in the audience. So who is going to put a balloon expandable valve in this patient?
You could do, huh? But,
And whose preference is for a self-expanding valve in this patient? Okay, so lots of people in the audience, I think, who are used to deploying self-expandings, and who probably would prefer a self-expanding valve in this patient for various reasons. I'm sure hemodynamics is probably one of the major reasons.
Ole, one other thing you mentioned that you were gonna use embolic protection.
Yeah.
Let's just talk for a moment about, is that your routine practice?
No. Yeah, well, we have the budget now to use it in 1 out of 3 cases. Of course, the economical factor is important. To be honest, to make it short, the reason why we did it is because this patient was in a trial too, so it's a study patient, we do it. And then also, sometimes if it's bicuspid, severely calcified, patients who had a previous stroke, to be honest, always. So we make a selection. I know it's not based on high evidence, but that's the selection we do.
Okay, all right. So the next 2 didn't get one, unfortunately. Okay. Any other questions in relation to this patient before we go and see how Ole and his team managed it? No? Okay, let's roll it.
Tell us a little bit about the patient on the table. Yeah, so the patient we have today here is he's a 78-year-old male patient with actually almost no medical prehistory, no other significant comorbidities, so which gives him a really low risk, but he's 78. And of course he has a severe aortic stenosis. He has a really severe aortic stenosis, I would say, with mean gradients of above 80 millimeters mercury. I think it was 85 millimeters mercury on echo, and a peak of more than 100. He has otherwise a preserved renal function, preserved good, well-functioning ejection fractions still of the left ventricle. So, and he's planned, of course, for transfemoral TAVI. Setting here is local anesthesia. We do not have anesthesia in the room. We have a nurse on the other hand here, Ida, who takes care of the patient and informs him on all the steps that he will undergo.
To the hospital
and we saw from the CT scan, tricuspid, heavily calcified valve.
So the patient we have today here
we saw no
he's a
particular
70
issues with the femoral access.
No.
In terms of your strategy, so this is a size 27 VitaFlow. We can talk about the device maybe in a moment, but you're going to use an embolic protection device. Your patient is an artist, so I think important to preserve that cognitive function. Right?
He's an artist who makes sculptures, so we would like to keep him in a really good shape.
In a good job.
Yeah, indeed.
Okay.
Yeah.
All right, so let's go forward and see how you do the case.
Yeah. So
this is the MicroPort system. So you'll notice that this is an inline sheet, 19 French outer diameter. A relatively short nose cone, and the inline sheet functions as all others do. The system is relatively flexible, as you can see, and even the capsule has some flexibility to it in all directions. You'll notice on the back end of the catheter here, this is where the deployment vehicle is. There's two buttons. There's an on-off and simply a deploy button and a retrieve button. We have a single place or pace for deploying the valve. But this, I suppose, electronic delivery is one of the novel features of this system. And failing that, should the battery ever fail, you have a manual lever on the back where you can deploy and recapture the system, and of course the usual flush port. So, quite an innovative system, and we can go ahead and check it now and make sure that that it's loaded properly.
Let's have a check. Okay, here we see it.
Yep.
The valve on the fluoro. So gentle clockwise turn.
So we don't see any buckling of any of the architecture of the valve, and we see the paddles are nicely in the pockets.
Yeah, that's good. Then.
Yeah, it's all perfect.
All right, that's good. Okay, then we prepare for pacing 180. You can start if you're ready. Yeah, that's good. All right.
So we're going to go up, Ole.
Yeah, go. Yeah, that's good. Down. Stop pacing. All right. Okay, stop pacing. You can put a stop pacing. Yeah. Yeah. Okay. I think we do it. Repeat it once again. Yeah. I like it. I mean, I want to make the optimal amount of optimize the number of fractures here.
The landing zone for the valve.
Yeah. I will go a little bit up. We don't have to go that deep into the LVOT. There's no reason for that. Okay, good. So pacing on again. He's very nice, stable hemodynamically. Yeah, we can inflate. Yeah, that's good. That's perfect. Yeah, down and stop pacing. So these pacing trains are very short, you know, it's like 3 seconds. All right, let's walk it out.
Hemodynamically irrelevant for the patient.
Yeah. Okay, that's good. So now we should have a really good predel. This was a 22 balloon. Yeah.
Around.
Indeed, we go LAO. Paspo for scam. All right, let's see there. Okay, I will zoom one out for you, then we can see both at the same time. I will take this away and I will do it the other way around, like this, vertically. Yeah. Okay, so we go gently.
Yep. Take our time.
Indeed, there's no need for rushing here.
Give you a little bit of traction as you come around.
There's a little bit of more acute angle there. There it goes. I take a small break here, so there doesn't come unnecessary push on these tissues of the aorta. Once again, I take a small break again. I think we can indeed, you have room for railing a little more there, Darren. Yeah, all right, and then indeed, we took it nicely there. Okay, and almost no interaction with the sentinel, but there is interaction with the pigtail.
Pigtail, huh?
Quite a lot, yeah. But okay, that we can reposition.
That you can manage. You have the skill set, I know this.
I hope. We go to 1624. Our cusp overlap again.
And so slow deployment, we get the nose of the device out, and of course you can do an aortogram at any point.
So now what I just want is that marker almost at the annulus, and then I'll let it dive maybe a little bit in, although the system is extremely stable. Typically it doesn't dive or go up at all. Okay, so we didn't give any contrast so far, by the way. But now what I will ask, now I suppose I'm around 3 millimeters below what I'm going to try to. So I'm going to ask pacing 130. Yeah. like that, then also the contrast stays there a little bit longer. It's not with one beat gone completely. Yeah. Okay, and then I'll here and I will do a little bit of contrast. Okay, we're only like 2 millimeters. So
just
picture
notice
is not
Ole's
fully
hands.
bottom. Okay,
He's
good to
doing it on
know.
his own.
So
It's
maybe
a single
just
operator
1 millimeter
implant,
lower.
right?
Like this, yeah. Yeah, okay, like this. I think now I'm around that 3. Let's see.
That looks good so far.
I think we are,
Perfect,
indeed.
huh?
Okay, so
Nice
then
and
now
central.
we can go even ask 160 pace. Yeah. Okay, and now we do a final injection. I'm happy with that,
I think
and
that's
I'm gonna go.
Look how the system doesn't move at all, huh?
100
Just
pacing.
stop just in a moment. Yep.
Yeah. Okay, that's it.
So you can even go a tiny little bit more if you wanted, Ole, just to
A little bit more caudal, less caudal.
Go a little bit more of
caudal.
deployment.
Ah, okay, that's what you mean.
You can bring it, go right to the top.
Yeah.
Okay. And now we can try and remove the parallax and see.
Yeah, maybe first I can try to go more caudal. Yeah, we're getting there almost. Yeah. Maybe, yeah, it's not too bad. Yeah, now I have, then I have a cable in front. But this is maybe acceptable, yeah? Yep. We have some cable of the machinery here, but I think it's okay. We can give a little bit of contrast here. Oh, this looks nice to me. We're at
2 on the notch.
2-3 millimeter on that side, and then for the left evaluation, we go
a little
to
lower, but you're so caudal there, it's hard to tell, huh?
Yeah, and we can go better maybe assess that in an LAO. That's why we do an LAO injection also, I think. And then, let's see, I think.
Patient, of course, is very stable. We're still pacing at 130, is that right?
No problem. 100. Okay, so this is for my assessment on the LCC depth. Yeah, okay, we're also there around 4 also. So 2 and 4. And the good thing is we pre-dilated well. It looks really nice expanded. Even if we go back to the previous, that's in the cusp overlap. That would be where the valve would be most constrained. It looks really nice expanded.
Perfect, huh? So you're happy to deploy. I think we've got a good depth. So we can go nice and slowly. We can take the tension out of the system by pulling the wire. And then nice slow deployment under, moderate pacing.
Yeah, okay, let's do that. Oh, let's see. Maybe I do it in this projection. It will be the best view also for the people. And then, of course, here we're on the higher-ish end, so I do not want to have push on the wire. To be honest, I want even to take almost everything off. Yeah, if you agree with that.
Yeah,
like a floating nose cone, just something like that. Not more than.
That's nice.
Okay, then we go slow. Maybe pace 130 again, like that we have a little bit less cardiac output. That would be nice.
The top of the system is very soft. You notice that there's an angle between the bottom of the system where you have a lot of radial force and the top where you don't have much.
Mm-hmm.
But it leads for a very central deployment, nice relaxed release. You don't tend to see much movement after the release. As your paddle is about to come off now.
Gently off.
There you go. Okay, one paddle off.
Yeah.
So that tells us end of travel. So I wonder is the
pacing
second
stop
off?
for 100 or 80?
It looks like it's off already, Ole.
Yeah, it's off. Yeah.
Okay, so we can.
And the valve stays super stable.
Yeah, it hasn't moved at all, huh?
Yeah.
So let's retract the nose cone nice and carefully.
Yeah. Let me give the chance to come first in the valve. Yeah, like that. Okay. Good.
We push the wire just a little bit.
Yeah, a little more.
Not the nicest wire position. Maybe I just pull it and push again.
Is that mitral again? Yes.
So maybe we leave it there, huh?
What happens if you push it tiny more? Sometimes it forms itself
forms its own.
Yeah, that's okay. Yeah. I'll zoom out for you.
So we can take this down back into the descending and simply recapture.
Yeah, you can say what you do here as a trick.
Yeah, so what we notice is that obviously when we recapture, in this instance, it's not the nose cone coming back down into the system, it's the system coming towards the nose cone. So as we retrieve, we can simply push a little bit on the wire and bring the nose cone back down. And I think it means that there's less chance of interaction with the aorta, with the capsule coming back.
Yeah. Okay, that's very nice.
And it self-centers.
Yeah.
There we go.
Okay.
Okay.
Sheet is ready. Again. Can I have a big serviette, please?
And then we do the typical exchange.
Yeah. Okay, I'm informing the patient. We will tracheolusken again.
Okay.
Yeah, that's nice. Okay. Hold the wire. So we had high gradients, 82 peak to peak. we had 26 kind of separation. So I think there's no gradient at all, as you can see. And the separation must be similar or even better, I think. Yeah, you can have a look. His ECG is also, we have normal AV.
So we look like we've got some gradient there, right? But I'm wondering, is it, are we zeroed well, or is this just a little bit of course, our pigtail is still behind the valve.
Yeah, that's.
I'm wondering, are we somehow damped on one of those traces?
Yeah,
because
that's
one of the
not the case at all.
The benefits of this system is that it's got a lot of radial force.
Yeah. No, that's totally not the case. I think we have no gradient here.
Yeah, I would so. No gradient.
No, that's just because of the contrast still in the system. Yeah.
So the diastolic was 45, 50 beforehand.
Yeah.
It's what, 54 now.
Same. Eh?
And the LVDP remains very.
See, we have 30 end diastolic separation. We had measured 20, but we knew there was some. It was probably 26. So we have at least the same or better end diastolic separation. We have 0 gradient. Okay. It looks very promising.
So maybe we take an angio and see what we look like in terms of.
This is actually
PVL.
a really good angle. There's no parallax here. It's the pure cusp overlap. Okay, let's have a look. It's excellent.
Okay, so
we're around 3 millimeter, 0 leak, as in all our cases with VitaFlow. I mean, this is truly excellent result. I think we have a nice high implant, 0 leak, commensurate alignment, good expansion of the valve, shows that the valve has good radial force. So
perfect contemporary TAVI, huh?
Yeah, really. I mean, we can't wish for more. In conclusion, I think we have a really great outcome for this patient. He's already talking, and so we know he has no stroke at all, or not procedure related, for sure not. We have great outcome from the valve, I would say. No PVL, no gradients. Also there, we see a small balloon branch block, but he has a preserved PR, as we saw.
Yep.
So I think we have a good outcome.
Yeah. So congratulations for you and the team on a great case, and we'll see you in London.
Yes. Thank you.
Great.
So maybe a little bit of truth on this. So I went over to Copenhagen, had a lovely dinner with Ole, and Ole did 5 cases with Microport, his first cases. So this was case number 4. And really, Ole, tell us about your 5 case experience.
Well, first on the outcomes of all 5 patients. They're all 5 patients when was next day discharge. They were all perfect, like no procedural complications, not vascular, not stroke-wise. Valve performance, I think in all of 5 of them, there was 0 to trace leak, yes. There was no gradient. And these were not hyper-selected patients, I would say. They were just the classical patients we have in our pool of patients. So according to that, I was super satisfied with the outcomes. Then about the feel, I think as you see, I think that was repeated in all of the cases. I was amazed by the stability, like how you deploy that valve doesn't go in or out or jumps
Oscar,
up.
you mentioned that earlier. You said the valve is really, and the system is a little bit stiffer coming around the arch and to come in. But I think the benefit of that is when you're deploying it, you don't, there's no movement, and you could see Ole's hands during the case. I don't think you had the intention of doing this as a single operator. No. It's just all of a sudden you just grabbed the front of it and grabbed the back of it and just did your thing. So I think it. Not intentionally, but it can give you, I think, a nice feel where you control as a single operator how the procedure goes. Not that having a second operator isn't a bad thing, but sometimes in maybe more challenging cases where you do have a lot of movement of the valve and communication can be a bit difficult, it's a nice option to have.
And even that stable rate that I was in the beginning maybe a bit more skeptical that you as an operator you want to control everything. Yes, I mean you want to I want to decide on the speed that I turn the wheel, etc. You have to give up on that idea, but then in fact I think it helps actually to get a better, nicer, equal expansion of the valve that maybe also helps in that stability. I mean a couple of factors. I think the straight part of that valve, that it doesn't force itself immediately out. The fact that you can use that mechanical deployment of it. So all these factors add to that was for me the most striking. The stability of deployment is enormous. Yeah.
Okay. Questions from you guys on that case or how it was performed? Anything that you'd like to ask, Ole? Yeah. Better catch this time, huh?
I'm improving. I just missed the coronary alignment phase of the procedure.
Yeah. Oscar, do you want to tell us about commissural alignment with this device? Is it possible currently?
It was not possible at the beginning, but now they are working. Probably, Oli, you can explain how you did it, because there you reach a perfect coronary.
Yeah, but I think this was just
great skill. It was great skill,
That's
right?
just beginner's luck. So that was not intentional. But okay, I don't know. I cannot answer on that if there's ways to be worked on that. But
So you can see that you can see the commissures on this device when it's actually in the device. And so there is therefore a very good chance to be able to have a good technique to commissurally align this. What I'm going to show you in a moment is their next generation delivery catheter, which has a couple of really cool features. And so that makes it actually, this device makes it a little bit harder to actually get commissural alignment. And the reason for that is that you have two new features here. You have this electronic delivery that you've all seen, but you have an automatic lock. So, for example, if you're in the middle of a case and it's a difficult case and maybe you don't remember to take your finger off the button and you deploy the valve maybe a little bit too quick, there's a lock here to stop you doing that. The second feature is that this is pretty much the first self-expanding valve that is going to give you steering around the arch.
Can help you holding.
Okay, thank you.
If it's across the arch,
so
maybe
if
we
you
should
look
show it across the arch. Like, whoop it.
I'm the arch. Maybe going the wrong way, huh?
Keep it lower, keep it lower. Yeah, like this.
So the ability to steer around the arch, truly get coaxial, stay away from that outer curvature, I think is a really nice addition. And ultimately in those very horizontal anatomies, now I'm not quite at maximal flex. So you see how much steering that you can get from this next generation delivery system. That's going to make, if you think about it, commissural alignment at the level of the annulus a little bit more difficult. And so what the company, I believe, are working on is to get that commissural alignment in an FX-like way in the ascending. And therefore you keep it as you come around the arch, but with the addition of steering to help you with those much more challenging cases. So this is their TAVI 3 delivery system. You're very welcome to have it here. You want to play with it, have a play with it. And so one of the novel developments that's coming. We have maybe just a couple of minutes, and I'm just going to, I think it's important to let you guys know where this company are going. The first thing I think to say is that commissural alignment is being worked on. So we're going to have a solution for that in the very near future. I think that's important for the company. The second thing to say is that the company believe that they're going to have CE mark by the end of the year. And so this device is going to be commercially available in Europe by year end. Now, obviously, the company have to work out sales force and all those kind of issues, but that's something that is important for them. You've seen the VitaFlow 3 delivery system. We've just showed you that, the steering around the arch, which should improve coaxial release, better stability, reduce vascular complications, and obviously improve safety for our patients. And this is an example of a case that is in a clinical trial in China using that steering mechanism, a very highly angulated aortic arch. And you can see that steering really just takes you down and brings you coaxial in challenging anatomies. You can see that this device is right in the center of the valve. So this is, I think, a good improvement. And then finally to say, in terms of evidence generation, I think that the company need to do this. Yes, they have the 7-year echocardiographic follow-up, but that's a very early patient cohort. We heard Angela say, look, this is 7 years ago. Does this reflect contemporary practice? And so as far as I understand, the company are going to embark on 2 studies in Europe. The first is a post-market clinical follow-up study in high-risk patients, which is going to be the CE mark. And the second is going to be a pre-market study that aims at indication expansion. That is to say, all levels of aortic stenosis risk rather than just the traditional high-risk patients for which they're hoping to get their CE mark. So with that in mind, I hope that you've been introduced to the MicroPort system. It is a novel system that is soon to be launched here in Europe. The company are here. They have a booth outside, so go talk to them if you'd like to use this system. I'd like to thank Dr. Zhang for coming over from China and giving us the 7-year data. Angela and I have done some cases together. Thanks for being with us. Ole, congratulate you on a phenomenal case. And Oscar, thanks for sharing your experience with us. And of course, thank you all for being here for this symposium. Enjoy the rest of the course.